Hello everyone, I am Dr. Masood Khan. Today we will discuss the history of a long case. It's my patient Muhammad Aslam, 55-year male, businessman by profession, resident of Gulberg, admitted in hospital through ER with chief complaint of worsening of shortness of breath since 1 week. According to the patient, he was alright 2 months back when he developed shortness of breath on exertion. Initially, the shortness of breath was gradual, insidious in onset, and it gradually increased in the last 1 week. Patient is unable to walk around and he gets breathless on doing his daily activities. Patient is now breathlessness is now breathless on walking a few steps. There is no chest pain, palpitation, or sweating. For the last 1 month, he cannot lie flat and awakens from sleep because of breathlessness and become better after sitting up. Shortness of breath is associated with cough and pink frothy sputum. Cough occurs occasionally and it contains 1 to 2 teaspoons of sputum with froth in it. There is no foul smelling of the sputum and you used to have 3 to 4 pillows for sleep. Cough occurs only on lying flat. There is no allergy, no associated vomiting, diarrhea, loss of weight, urinary complaints, headaches, fits, or motor weakness. Patient also experience some episodes of palpitation that he feels like his heart is racing, that settles down by changing up the posture and by going to the window. There is no history of diabetes mellitus, hypertension, ischemic heart disease. However, patient is a known ex-smoker and patient has 35 peg years of history. Patient has no history of congenital or valvular heart disease and has no tearing chest pain that radiates to the back. Patient denies any dental procedure, IV drug abuse, illicit drug abuse, cocaine. However, patient experiences whistling sounds in his breath when breathing, and there is no use of inhalers or biomass fuel or exposure to dust. He quit smoking 3 years back when he was admitted in a cardio unit after suffering from an anterior myocardial infarction. Patient denied any history of tuberculosis contact or active tuberculosis, low grade or high grade fever, night sweats. Patient also denied any history of lumps and bumps, inhalation of or nebulization, and there is no history of decreased appetite. There is no history of any fluid collection in lung. He also denied significant air flight, or there is no history of prolonged immobilization. Patient also denied sudden shortness of breath that or any epigastric pain or discomfort, regurgitation of food, blood in the vomiting or blood in the stool or black tarry stools. Patient also denied any chest trauma or pain in the muscles, joints and back. Patient developed shortness of breath since last 1 week. It's worsening. However, there is a past history of a heart attack for which he was admitted in hospital 4 years back, and he was told that he has suffered from anterior wall myocardial infarction, for which he was treated, and he followed the advice of quit smoking. Patient is having good dental hygiene. There is no history of gastroesophageal reflux disease, stroke, aspiration, any ICU admission, any ventilator support after that. No history of exposure to fumes, factory dust, birds. Now, past history includes there is chest pain due to MI 4 years back, for which he was treated and he is on regular medicine, that is aspirin, clopidogrel, and atorvastatin. Patient is a businessman, a cloth shopkeeper, but does not have any allergy related to clothes. The patient's father died because of stroke. He has one sibling who is healthy, two sons, all are healthy, and no family history of tuberculosis, diabetes, or hypertension. On examination, patient, a middle-aged man lying in bed comfortably with vitals, blood pressure 110 by 70, pulse rate 100 per minute, that is regular in character. Temperature is 98.6 degree Fahrenheit. No jaundice, clubbing, chylonychia. No ossular nodes, Albertan nodes, Palmer erythema. No axillary lymphadenopathy or inguinal lymphadenopathy. There is no ankle edema and sacral edema. The cardiovascular system includes pulse 115 per minute, that is low volume, and there is no special character of the pulse. The pulse is palpable on inspiration. Apex beat is visible below and lateral to the left fifth intercostal space, mid-clavicular line. There are no scar marks over the chest, no visible pulsations. No thrill or no added sounds. Abdomen is soft in consistency. There is no hepatomegaly, no splenomegaly. The gut sounds are audible. However, in the chest, there are bilateral basal crackles associated with bronchi and wheezes. There is a pansystolic murmur which is auscultated in the midline at apex and it is radiating to the axilla. The intensity of this murmur is 3 by 6. It's loud during expiration. Trachea is central in place, no chest deformity. The chest movements are equal bilaterally. Higher mental functions are intact. Speech is normal, cranial nerve intact. He can move all four limbs and can appreciate the sensations in all four limbs. Now, this was the patient's history and examination. History includes an insidious onset of shortness of breath since 1 month, which gradually increased during the last 7 days. So, progressive dyspnea is the chief complaint for which he was admitted, and on examination, there are bronchi bilaterally. Patient use pillows 3 to 4 in number and is more comfortable in sitting position. And there is a murmur of mitral valve regurgitant murmur that is pansystolic grade 3 by 6, loud during expiration and is radiating to the axilla. Now, how to approach a heart failure patient. First line is very important, that is the gradual and insidious onset of shortness of breath with orthopnea and PND. The most common cause of right heart failure is left heart failure itself. So in this patient, the progressive dyspnea, we have a list of differential diagnosis and we will discuss it each and every differential. Like patient in this case is not hypertensive and he is not diabetic, but he is a ex-smoker and is having ischemic heart disease for which he was treated 4 years back. Now this current shortness of breath, it initially started on exertion only, then it has reached a state that is resting dyspnea and difficulty sleeping in supine position, and patient is becoming dyspneic while attending his washroom or minor activities of personal hygiene. And patient also gives history of awakening of sleep because of shortness of breath. Patient denied any seasonal or diurnal variation or any inhaler used in the past. So now patient is having on examination pedal edema and generalized swelling of the body. However, there is no distended engorged neck veins. There is no yellowish discoloration of sclera or abdominal distension. Now, in this patient, the differential diagnosis includes acute pulmonary edema, congestive heart failure, constrictive pericarditis. These are our top differentials in this patient. However, patient has suffered an ischemic heart event in the past and for which he is taking medications. So the patient, in this case, we have to look for the association of the chief complaint with other diseases like diabetes, hypertension, or poor compliance to the medications, and any dialysis advised in past, or he has any dialysis event performed. There is no history of dialysis, and so we have to rule out the chronic renal failure, which also presents as acute shortness of breath. Patient is taking the medication for hypertension, the ACE inhibitor, rosuvastatin, aspirin, and clopidogrel. Patient also denied any history of cerebrovascular accident symptoms like extreme headache in the past, or any weakness, focal or generalized weakness, hemiparesis or paraparesis. Now, cardiomyopathy is on the top, and we have three types of cardiomyopathy. One is the dilated cardiomyopathy, then there is restrictive cardiomyopathy, and the third one is hypertrophic cardiomyopathy. A dilated cardiomyopathy is associated with alcohol, chemotherapy, and radiotherapy, while autoimmune diseases also involves the myocardium and presents as cardiomyopathy. Certain viral infections that lead to myocarditis, it can present as uh, shortness of breath, and however there is another entity, the hypertrophic cardiomyopathy, which is very common in long-standing hypertensive patients. The restrictive cardiomyopathy causes includes tuberculosis, amyloidosis, sarcoidosis, glycogen storage diseases, and for TB we have to take history of the fever pattern, that is low grade fever with evening rise and associated sweating. For amyloidosis we have to look for tongue size that is enlarged. For sarcoidosis, dry cough and painful skin nodules may be present. So in this patient, there is history of ischemic heart disease in past and a smoking history for 30 years, and patient denied any history of valvular heart disease, and so now we have to inquire about the complications of heart failure. That is decreased urinary output secondary to decreased ejection fraction. The cardiorenal syndrome, at times it presents as syncope, recurrent syncope, postural hypotension, thrombosis. In like presentation is deep venous thrombosis, any leg pain or any swelling in the leg or calf muscles. Now, pedal edema approach. First of all, we have to look for infection, anemia, paleness of complexion. The ischemia or ischemic heart event may present as pedal edema. Increased salt intake history we have to rule out, and loss of compliance with medication, increased use of NSAIDs, steroids, or any herbal or Hakim medication. Syncope and drowsiness is also associated with congestive heart failure. Now, there are right heart failure and left heart failure. The right heart failure is secondary to left heart failure. So, if both are present, we summarize it in as congestive heart failure, and there is generalized body swelling. The left heart failure signs include the symptom include the pink frothy sputum, orthopnea, P&D, and the right heart failure sign includes right hypochondrial pain, jaundice, abdominal distension, and pedal edema. How to investigate such a patient? It includes ECG, echo, color Doppler, and angiography. We have also we need to inquire that is there any hospitalization, multiple hospitalizations, any surgical procedures, and any travel history, any blood transfusion or any blood loss, any vaccination, especially the H influenza vaccination and pneumococcal vaccination patient has in past or not. Now the functional status is who is with the patient in hospital. Does the patient is able to perform his daily activities independently or with support of someone? So our differential diagnosis in this patient includes heart failure precipitated by ischemic heart disease or congestive cardiac failure precipitated by chest infection. On examination, the general physical examination includes clubbing or nicotine staining, uh, the carbon dioxide retention signs, skin bruisability, the infective endocarditis marks, anemia, jaundice, lymphadenopathy, pitting pedal edema if positive. So it's very important that the upper limit of the edema up till the shins or thigh or abdominal wall involvement. We have to auscultate all four areas of the heart. Any murmur, like in this patient, we appreciated the mitral regurgitant murmur with S3 and S4, a gallop pattern, and in sitting position, we appreciated the sacral edema, while the back of the chest expansion and auscultation in the upper, middle, and lower zones we performed in this patient. So this was all history of congestive heart failure. Now, some other important points like what is heart failure? By definition, is a clinical syndrome with sign and symptoms secondary to structural or functional cardiac problem plus increased BNP or evidence of cardiopulmonary enlargement or congestion. There is a criteria, Framingham criteria for the diagnosis of congestive heart failure, a major criteria and minor criteria. For diagnosis, two major or one minor plus two major, one major plus two minor is the criteria. The major criteria includes acute pulmonary edema, cardiomegaly, hepatojugular reflex, neck vein distension, PND, orthopnea, rales in the chest, S3 gallop. The minor criteria includes ankle edema, shortness of breath on exertion, hepatomegaly, nocturnal cough, pleural effusion, heart rate more than 120 per minute. There are certain trials for heart failure. It includes the CHARM trial, the COMAC trial, Paradigm trial, RAILS, DELIVER trial, Emphasis trial. Now, what are the drugs which are used in heart failure? It includes the ACE inhibitor, beta blocker, ARBs, and ARNIs, ARNI. These are the common drugs we use in such patients. Now, heart failure has further classification. The classification includes heart failure with reduced EF, heart failure with preserved EF. So reduced EF, in which the ejection fraction is less than 40%, and normal